Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity is supported by an independent educational grant from Regeneron Pharmaceuticals, Inc. and Sanofi.
Hi, I'm Dr. Michael Wexler, Professor of Medicine in the Division of Pulmonary Critical Care and Sleep Medicine and Director of the National Jewish Cohen Family Asthma Institute at National Jewish Health in Denver, Colorado. Welcome to this program titled Empowering Choices in Moderate Severe Asthma, Partnering with Patients for Optimal Treatment Decisions. Joining me today are Priya Aya, a nurse practitioner at the primary care practice of Beth and Howard Braver in Hollywood, Florida, and Ryan Kramer, a family physician in Denver, Colorado, and a patient with severe asthma. Welcome. We've seen a significant change in the management in treatment of moderate severe asthma in the last few years. We have new treatments. We've moved from simply controlling symptoms to talking about remission. And there's been a lot of new research on biologics and their impact on airway remodeling and other features of the pathophysiology of asthma. But despite these advances, there's still several unmet needs that include we need to improve treatment adherence. We need to optimize inhaler technique. We need to better identify all the different asthma phenotypes. And we need to do a better job in terms of managing comorbidities. Today, we'll discuss some approaches to those challenges by sharing different perspectives, including some of a patient and of a primary care clinician. Throughout this discussion, we'll emphasize the importance of shared decision-making, patient education, and early intervention with new treatments. Before we begin, I want you to pause and think about a recent patient with moderate or severe asthma whose treatment plan seemed optimized, but whose day-to-day control remained poor. What factors do you think might have contributed to this disconnect between guideline-based care and real-world results? So let's get started with our program. So to help us better understand the true impact of this disease, I'd like to start off by asking Ryan to tell us about your experience living with severe asthma and how it impacted your daily life. Ryan?
Thank you. It was a severe impact. I had very bad asthma, which started unusually near the age of 60. And I was referred to National Jewish, and the impact was huge. We found out that my triggers were largely fragrances. So because I'm a physician, and if I had to take off somebody's shirt and they had Old Spice deodorant, within 2 hours I was on oxygen. So that's a very brittle asthma. It was a very scary and debilitating experience. Most asthma attacks happen at night, so I got very little sleep. I also had nasal polyps. It was called dryad asthma in those days. And you don't sleep well if your nose is obstructed. So I was always fatigued. I was always yawning. Patients left me because I was tired instead of being able to pay attention in the office. Myself and family members were fearful that I might die. So this was a very scary experience, or at least I was also fearful of being intubated and being in hospital on a ventilator. And we had a rough time of this. I would miss many family events. I would have to stay at the office nebulizing, and I was using, because I'm a physician, I was using adrenaline, epinephrine, because it worked really better. But and so I missed many family functions, just called home and said, I can't leave yet, I can't drive yet. So this was very severe and very debilitating. And fortunately, pharmaceutical science caught up. And we tried a couple of in clinical trials, we tried a couple of the different biologics and finally found one that is like magic for me. I went from using an inhaler or adrenaline shots or nebulizers 30 a week, that's a heck of a lot.
Wow.
To maybe 3 times in 4 years. So this was magic medicine for me.
Amazing. So,
Yeah,
so,
I
so
like.
it sounds like there was a huge impact on
Oh,
your everyday life, on your work, on your family life, and it must have been quite scary for you to experience all the symptoms that you had. So let's pivot now a little bit to talk about the current treatment landscape for moderate to severe asthma. I want to start off by talking a little bit about systemic corticosteroids because it sounds like you may have used a fair amount of prednisone to get you through these episodes. And we know that while steroids are effective, there are a lot of short term and long term side effects of systemic steroids, of prednisone, even when used just intermittently. And each prescription for oral corticosteroids can result in a cumulative burden on both current health as well as future health. And that's regardless of the dosage and duration of use. So, for decades, really before all the biologics emerged, we relied on oral steroids to treat and control exacerbations, and we still do to this day. But one of the major goals that we have is to try to prevent these exacerbations from happening. Because while steroids are effective, they reduce inflammation, they reduce hospitalizations, and they can save lives in the emergency setting, the side effects are quite substantive and really are additive over time. And it ends up being that many patients historically would go on chronic oral corticosteroids. And despite their efficacy, the number of adverse effects were really significant. Priya, what are some of the short and long-term impacts of oral corticosteroid use?
uh, tons of side effect, weight gain, high blood pressure, hyperglycemia, a swelling of the face, a lot of acne, immunosuppression, GI upset, mood changes, depression, a myriad of effects. As much as steroid is powerful anti-inflammatory and helps patient right away, specifically when they can't breathe, staying on steroid long term affects them greatly, bone health, heart health, and uh, this is what can be prevented by using the new mode of treatment for their persistent severe asthma.
Yeah, I think, there are both the short-term effects, and Ryan, I'm sure you experienced some of those when you took steroids. But both, the weight gain and the fluid retention and mood changes are frequent. But even long-term side effects that we see with steroids, the osteoporosis, cataracts, glaucoma, diabetes, and risk of cardiac toxicity. Ryan, did you experience any of those as a patient taking
so
systemic steroids?
in a weird way, I was spared that because the steroids did not work. If I
Oh,
took steroids, it took 3 days for them to be of any value before my peak flows would start improving. So I took it very intermittently. And when I took them intermittently, my brain wouldn't work well. I would be elated. I would have heartburn, ravenous, hard to sleep. So there were a number of things from just taking short term. Mostly I took 5 or 7 days of steroids and stopped.
okay. But even those short
Very
courses can be associated with both short-term side effects, as you described, as well as long-term side effects that we have reviewed as well. So let me pause again and ask our audience. Think about your last patient who required oral steroids. What strategies did you use to explain the potential risks, and how did you support them in understanding alternative treatment options? Priya, how do you talk to your patients about the risk of systemic corticosteroids?
So discussing them because they make them feel better right away. Patients takes that's the right medicine and they want the steroid every time they're not feeling better. So even though I teach them that even though they are powerful anti-inflammatory, the long-term effects are very detrimental to their health. And uh, treating the asthma with a maintenance inhaler, teaching them proper maintenance technique is the goal of asthma, not the taking steroid for a long period of time.
Yeah, no, I think those are important ways to address this issue with patients. Ryan, I remember that you talked a little bit about having what you called steroid brain, and you had sleep disturbance. How did that impact your day-to-day life, and emotionally, how did you get through?
Um, it's very hard to feel not in control of your brain. And so I could tell I could not think straight. I could tell that I was feeling elated. Um, I must say steroids were not a godsend for me.
Yeah. Priya, what sort of follow-up questions would you have from a primary care perspective to ask Ryan about?
Well, the main thing I would ask is that when he couldn't really breathe, was he able to think about those side effects of steroid, or he just wanted to take
No,
them?
no, you just want to breathe. And so I'm
Yes, yeah.
sitting with oxygen, with a nebulizer and a peak flow meter and a pulse ox on my finger. And that would be between 1 and 3 hours to get rid of one bad attack. It was, you can't think much about anything else at that time.
Right. And I think that's where we are today, that patients, when they can't breathe, they do want to take steroid. But as a primary care provider, it is important to get them to specialist or get them to a step of treatment before they need another round of steroid and get to that cycle of just taking steroid for their asthma exacerbation.
I think that's an important take-home message is referring patients from primary care to specialists when asthma seems poorly controlled. And the reasons for that is because not only might there be specific therapeutic options, but also there can be specialist efforts to try to untangle what the issues are and whether there are other comorbidities, plus working on adherence related issues, and also trying to identify what a specific phenotype is that one could target. So we're fortunate, I have to say, that in the last decade or so, we've had several new biologics that have emerged that target type 2 inflammation and have become available for us as clinicians for use in our clinical practices. And what we've seen with these biologics is they can have a significant impact in terms of reducing the burden of severe asthma, but also the burden of oral corticosteroids. And these biologics have been shown to reduce exacerbations, improve lung function, and they can also have a significant impact in terms of controlling symptoms, despite otherwise optimized treatment with inhalers. And we've shown that both both from clinical trials, but also from real world data, that biologics are beneficial from an oral steroid sparing effect. So, Priya, many patients seem to benefit from these biologic therapies, but timely identification and referral to specialists is key. Can you share when you decide to refer a patient with uncontrolled asthma to a specialist?
So one of the key component is a history taking from a patient if they are new to practice and if they have used, if they are on maintenance inhaler, if you see in their EMR that they have used steroid, I send them to specialists right away. And if these are my patients, if they have asthma exacerbation while on a maximum tolerated ICS SLABA, send them to specialists right away because their asthma needs to be looked at, evaluated, and step-up therapy is needed.
So, as a specialist, I welcome the opportunity to take care of those patients. Sometimes patients come with, they just come and give me their history. And sometimes they come prepackaged in a way, and the primary care specialist does a little bit of a workup. So, what sort of workup do you do before you refer the patient, and how do you package those patients so that they're a little bit easier for me as a specialist to appreciate what's going on and decide what the next step is?
Um, so few basic preliminary things that definitely one of the most important thing that I work with my patients is a proper technique for using their maintenance inhaler. CBC with differential chest X-ray allergy panel. Um, if they have nasal congestion, I also try to do either CT of the sinus or the X-ray of the sinus to rule out polyps, rule out any acid reflux related asthma if they have H. pylori infection, but basic preliminary work to see if they have eosinophil count higher or IG, and then tell them to discuss their asthma with their specialist.
Great. You know, it's really, really helpful. I'll tell you the strategies that I utilize when I get referrals from primary care, from patients who come in directly. Is the first thing I want to do is make sure the patient has asthma and confirm the diagnosis. And so getting some of the testing that you ordered is really helpful. Second of all, I also focus on adherence. And is the patient taking their inhalers as frequently as they're supposed to? And are they using their inhalers properly? The third thing is I try to address some of the comorbidities that you mentioned. Do they have concomitant reflux or sinus disease or aspiration or vocal cord dysfunction? And then I want to know what type of asthma the patient has. Do they have type 2 inflammation? Do they have eosinophilic asthma? Do they have allergic asthma? So, utilizing the strategies that you've done in advance by ordering that CBC, by getting an allergy panel, by doing an IgE, by getting a chest x-ray is really, really helpful. And then, I'll often get maybe sinus films or maybe a chest CT or maybe do some more of a GI workup to see what's going on. But once the patient comes in and we've done all that workup, really, I'm starting to think about using a biologic to try to take care of my patient, to prevent the exacerbations, and to minimize the use of oral corticosteroids. So, an important question is what are some of my considerations as a specialist for choosing a biologic? And I would say there are a lot of things that we consider. It isn't always so straightforward. Usually, we start off by looking at the biomarkers. And is there a dominant biomarker? Does the patient have a dominance of eosinophils? Do they have significant allergies? They have high nitric oxide. So that's part of it, understanding what is the patient's phenotype. The second piece is evaluating the patient's history. How severe is their asthma? Do they have exacerbations? How frequent are the exacerbations? Do they go to the emergency room? Do they go to urgent care? How often are they using steroids for their asthma? What about antibiotics? Are they taking antibiotics for what's perceived to be an infectious stimulus of asthma? And then it's important to talk about what are the patient's expectations and addressing all the other comorbidities. So those are all the things that I do when I see a patient for the first time, and I'm trying to figure out what can I do as a specialist to make the patient's asthma better and get the patient better controlled. But as we think about the evolving landscape of asthma treatment, it's clear that choosing the right therapy isn't just about those clinical indicators. It's also about understanding each patient's goals, each patient's concerns, and each patient's preferences. And when you look at sort of the body of literature out there, it's been demonstrated that engaging patients in their healthcare decisions and considering their preferences really can have a significant impact in terms of improving adherence and ultimately leading to better outcomes. If patients understand why they're taking the medications, then they're more likely to take them. So there's a growing number of biologics that have emerged, and these have become available for patients with moderate to severe asthma. So it's important for clinicians to understand the patient perspective and really engage patients in these shared decision-making processes when establishing a treatment plan. It's really important to educate patients about all the different options. And as part of that, to use plain language and decision aids, and really to understand the patient's priorities, asking
Yes.
patients about their goals and what do they envision their life looking like with the right treatment option. And so in discussing with patients, I want to talk about the attributes of the treatments, how frequently they're administered, where they're administered, what the potential benefits are in terms of lung function, in terms of exacerbations, and the potential to treat other chronic conditions, because many of the biologics that we have not only treat the asthma, but can also treat, for instance, chronic sinusitis and atopic dermatitis. And so, Ryan, can you just give us a little bit of insight? Did you have any of those comorbidities? Did you have sinus issues or any other
Yeah,
related conditions?
I initially uh, I had a CAT scan and every sinus but two were full.
Wow.
Um, I also had polyps and I had 3 polypectomies uh, before the biologics. Being a family physician, our major value is actually management. And so each patient is different, and you have to figure out what that patient wants and trial and error. It happens that even before I got ill, asthma was one of my areas of interest. And so I have a pulmonary function machine at work. I have oxygen. I put people on peak flow meters and monitor them. If I start them on a preventive treatment, largely they were inhaled steroids or even montelukast or something like that. I want to see that they're benefiting from it to warrant taking something for 10 years or something like that. So mostly I will get a peak flow or I'll get a full pulmonary function test. It's not as complete as what I would get at National Jewish, but it's pretty good.
Yeah.
And then I'd put them on treatment and reevaluate them with a pulmonary function test in the office. And if the medicine worked, it would show. And if it didn't work, why use it? And
Yeah,
so,
well, you raise a lot of important points. First of all, about personalizing your approach to each patient and giving the right patient to the right drug to the right patient at the right time, and that's so important. And the other thing you talked about is really how do we monitor the patient afterwards? And so, I want to ask the audience to sort of reflect on this and think about how you partner with patients to monitor asthma control between visits. Do you use symptom diaries? Do you use electronic monitoring or just regular check-ins with your patients? So, Ryan, after biologic initiation, it's so important to ask the patient, how are they tolerating it? How are they feeling? What are their breathing tests like? What's the biomarkers like? What's happened to the nitric oxide? And one of the tests that we utilize is, we have questionnaires for our patients so that when I follow up my patient, I get a sense of how they're doing. First of all, we do the objective testing, the pulmonary function testing, the nitric oxide testing. And even before I go in the room, we have had patients who respond to questionnaires, either the asthma control test questionnaire or the AirQ questionnaire or other exacerbation questionnaires. And that gives me some sense of how the patient is doing. And then it's important to let the patient know to communicate with you as a physician about any possible unresolved symptoms or any continuing symptoms that they may have. And it's important to combine evidence-based approaches for monitoring with the patient's own observations about their day-to-day symptoms, their triggers, and their quality of life. Priya, sometimes patients aren't able to see their specialist regularly. So it's so important to collaborate with primary care. So how do you monitor your patients in the primary care setting?
So if the patient is already being seen by specialist, the most important thing I appreciate from specialists is their consult notes to know that what was discussed with the patient and what is the moving forward plan. Um, Real world, the ideal world would be that they continue following specialists and have their appointment regularly, attended. But unfortunately, the real world is not the ideal world. So there are many times primary care ends up managing these patients on biologics. So having a partnership with a specialist about their the maintenance inhalers, about their biologics, about the follow-up PFTs, serial PFTs, or any kind of uh, follow-up that they need. Um, Also, if this patient comes to primary care with asthma exacerbation requiring steroid, and despite being on biologics, they need to be followed up by specialists to see if they need to be changed to different kind of biologics. So I think that partnership with specialist and primary care is very important for the management of patients' asthma. Um, I actually have a question about PFTs. How do you, as a specialist, feel about primary care doing the PFTs?
You know, the studies have shown that uh, primary care physician and primary care practices can do PFTs. They can do them well and they can interpret them. But they obviously need to have some training and be educated to make sure that the interpretation is appropriate and that the breathing techniques are done. So it can be done, it should be done. And I think there's an important role for primary care to utilize pulmonary function testing. Even measuring peak flow, which is a little bit easier, can be done in primary care as well. And, you know, I expect to get some of that information, either the patient to have pulmonary function testing ordered by primary care specialists. Otherwise, we'll do it ourselves in our offices. Are there any other key teaching points that you add to patients in your practice? And what about, do you document the number of exacerbations that a patient has? How do you keep track of those kinds of things? And how do you evaluate inhaler adherence in that type of strategy?
So definitely one of the, I mentioned earlier about maintenance inhaler. I stress on it. I actually have them bring it to the office and teach them a proper technique to use it, rinse their mouth afterwards, because uh, maintenance inhaler is one of the most important treatment for asthma. Asthma control test, asking about their exacerbation. Also, if they are on biologics, to make sure that they uh, get their biologics on time. There are a lot of issues related to biologics, whether they are getting it from specialists, whether those biologics are being delivered to their home or they are going to the specialty administration places. So this just partnering with patient, what is happening, all that, and documenting it, all that is very important. As a specialist, what are your expectations from primary care as far as management of asthma?
Yeah, I think the key thing is communication. I want to know what's going on, and I think it's important for the primary care specialist to communicate, how the patient is doing, if the patient isn't responding, and if you can provide some objective data, whether it's pulmonary function testing or information regarding exacerbations, that's really helpful. How do you generally communicate? Because that's such an important piece of the care of these patients. How do you communicate with the specialist in your practice or the specialist that you interact with?
Well, our EMR is pretty good, so we have a secure chat to discuss with the specialist. So I directly message them, and if not, then pick up the phone and call them and ask that I need to speak to you regarding this patient. Old fashioned way.
Yeah, I think picking up the phone is the key piece. And another question I have is how much do you want to take ownership of the patient with severe asthma? And how much do you want to manage the patient? And how much do you want me as a specialist to manage those patients?
Okay, so ideally, actually, I would rather have specialists manage the patient as a primary care, because as a primary care, we manage quite a few of disease process, and I don't want asthma to fall through the crack, because I'm also managing osteoporosis and diabetes and high blood pressure and depression. And I cannot ask patient to see 10 different specialists. So that would be the ideal. But if there is a partnership between specialist and primary care, then I can take partial ownership of the management of the asthma, that the patient is taking their maintenance inhaler, they don't have asthma exacerbation, immunization is up to date, and stuff like that.
Yeah, really, really important to communicate. And each primary care physician is different in how much control they want to have. But the key thing is to have open communication, pick up the phone, and I try to do that with after every visit. You know, particularly if I have a good relationship with the primary care doctors, I'll pick up the phone and say, "Yeah, I just saw Mr. So and so, and you know they're doing okay, or we need to escalate therapy. You know, will you follow up with them in a couple of weeks just to make sure they're doing okay in case I can't as well?" So yeah, those are key components. Another question that comes up often is, you know, patients who want to stop their inhalers and, you know, once they get better control and what to do with their biologics if they get started on a biologic. So it's important to think about those kinds of things, both in primary care and as a specialist. And remission is a new buzzword that we've started to talk about in asthma. It is feasible. And when we talk about remission, we're talking about having no exacerbations, requiring no oral corticosteroids, having stable lung function, not having significant symptoms that interfere with one's daily life. So that's a bit of a high bar. But with the biologics, we can get maybe 30 to 40% of patients into some degree of remission. And then that's when we start talking about what to do next, what to do when a patient gets into remission. And I think it's important to set that bar pretty high because we don't want our patients to lose control, but patients sometimes want to come off of some of their therapies. So many patients remain reluctant to stop their therapies, but some want the option. And it's been shown in a couple of studies that you can cut back on inhaler utilization without a lot of risk. And maybe you may even be able to stop biologics in some patients, although for most studies, it's been shown that if you stop a biologic, the patient may have a relapse. So it's important to, first of all, set the bar high, set high goals for our patients, start talking about remission, not just as a specialist, but also as a primary care doctor. I think it's important to talk about remission as well. And our goal really should be, and this is what I've talked to Ryan about in the past, is to really aim for no exacerbations, no oral steroids, stable lung function, minimal symptoms on the biologic. And really, I think that's an achievable goal for many of our patients if we can control many of the related conditions like sinus disease, like reflux and whatnot. So it's been really exciting for me as a specialist to see our patients really have an impact on their asthma. So great discussion today. I want to thank you both for this great, fabulous discussion, the importance of communication, the importance of referring patients, the opportunity to treat patients with biologics. We now have 7 biologics approved for asthma. So it's a really exciting time to be managing these patients. So thank you both for this great discussion. And I want to thank the audience as well for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.